Well, good morning, everyone. I hope you're doing well and staying warm. Our office was closed today due to the cold winter weather and ice and snow and all that. So I am coming to you live, I guess not really live, recorded from my garage in my car because my kids are all home from school as well. And so it's very loud in my house. So forgive the amazing light and my, fluffy sweatshirt thingy-majiggle here. Anyway, this week we've been talking about vulvodynia and all the different kind of components of that. And so, this video is going to be kind of a conglomeration of those specific stories that I've been putting on Instagram. So this will be obviously up on YouTube for as long as you want to view it. Send it to your friends, or if you're in any type of, groups that are for people who have vaginas with vulvodynia or vestibulodynia, share the information out there. So anyway, a couple of just kind of things basically to start off with. The first, vulvodynia is not a condition by itself. It is a symptom. The word just means pain in the vulva. Vestibulodynia, once again, not a condition, just a symptom, and that's pain in the vestibule. And from an anatomical standpoint, the vulva basically encompasses the labia, both majora and minora, the clitoris, the perineum, kind of the structures on the outside of the reproductive tract. The vestibule is the amount of tissue from what's called Hart's line, which is halfway down the labia minora to basically the hymenal ring or hymenal remnant. It also contains the urethra, and also a lot of different glandular structures. Now, from a hormonal standpoint, the vestibule is very, very rich in androgen, like testosterone receptors, as well as estrogen receptors. So whenever we have patients that come in with any type of hormonal vestibulodynia, we always want to think about testosterone in addition to estrogen. So getting that stuff out of the way, if you want a more in-depth look at that, check out the blogs on my website. That's just www.corybab.com. I have a whole kind of list of anatomy blogs on there if you want to delve deeper into that. So anyway, so vulvodynia. Basically, when we look at vulvodynia, we can break it down into kind of three main divisions. The first is going to be, is this related to a neuromuscular component? The second is going to be, is this something hormonal? And the third is it something dermatologic? Now, we talked last week about all of the lichenoid dermatoses of the vulva, and that's things like lichen sclerosus and lichen planus. And those are obviously very common, but you can also get things like psoriasis of the vulva, or you can get Crohn's disease that manifests in the vulva too. So I'm not going to necessarily talk on those a lot today because I've already dedicated time to that. You can check out that video from last week to talk about the lichenoid diseases, but just know that some causes of vulvodynia are related to just problems with the skin itself. Now, that said, it's a lot of times really difficult to determine where the actual root cause is, and that is kind of the core at treating vulvodynia is where is the actual problem. Remember that itching is typically the first symptom a lot of people with vagina will kind of complain about. They'll say, hey, I've got this itching on my vulva. It sometimes keeps me up at night or it wakes me up. Itching is kind of the most mildest firing of our pain fibers. So it's the same type of what's called nociceptive system. It's just that the pain fibers are not really super duper engaged, so you actually get just kind of an itchy sensation. Now, if it's on one side versus both sides, that can really play into some things and kind of give you an idea about what's going on. And so in order to kind of look at this, let's kind of step back a second and talk about kind of nerves and muscles that go to the pelvis and how that can play a role in vulvodynia. So the most of the pelvic nerves come out of the lumbar vertebrae or lumbar spine as well as the sacrum. The big kind of nerve, bundle that we talk about a lot with vulvodynia is what's called the pedendal nerve, and that can lead to pedendal neuropathy or pedendal neuralgia. The pedendal nerve comes out of the second, third, and fourth kind of sacral vertebral kind of areas. They kind of fuse together to form this big nerve that courses down kind of back through your pelvis, and then it exits out into your groin, and then it has three branches. So they kind of split off like this, with one branch going up towards the clitoris, one going to the perineum, that's the area between the vulva and the anus, and the third one going down to the anus itself. Now, these will typically present as kind of more superficial pain kind of in those areas. And if you have a pedendal neuropathy, a lot of times, especially if it's just one-sided, you'll see that the skin on that side of the vulva tends to be a little bit more red and irritated. It may be retracted some as well. So if you look at your vulva and you see, one side's looking kind of different and I have pain on that area, that could give you kind of a sign that we may be dealing with some sort of nerve issue. Now, typically, if it is a bilateral nerve problem, what you're going to see is a actual kind of spinal pathology or spinal cause from that. And that could be something like either a disc that has kind of ruptured on both sides. It could be even higher up, in the whole spinal column, all the way up to your brain, to where the kind of sensory processing portion of your brain, is being triggered there. Usually, however, vulvodynia, that is not related to like a disc issue or a specific spinal issue manifests more on one side as opposed to the other. And this is because as that nerve kind of courses through the pelvis, it gets squeezed by different muscles. So it goes through muscles. And, if here's kind of a muscular tract and there's good space there, those muscles aren't contracted, it can go through no problem. But if those muscles contract down, it clamps on that nerve and it causes impingement and causes squeezing, and that yields pain. And you can a lot of times kind of say where this impingement is occurring based off of where the patient is feeling pain kind of at that end origin. If it's just around the clitoris, well, maybe that clitoral branch of the pedendal nerve is getting compromised. If it's clitoris and perineum, there you go. If it's just kind of the perianal area, there you go, so on and so forth. Now, obviously, with pedendal neuropathy, pedendal neuralgia, we also want to do a really thorough pelvic floor exam because that nerve is coursing through some of those deep pelvic muscles. And so if that pelvic floor is spasmed, that can cause that kind of painful sensation on the vulva. Typically, pelvic floor exams basically are done intravaginally and kind of figuring out which muscles are actually spasmed. Patients may have kind of pain that radiates to the anterior pelvis. It may go to their buttocks. It may go up to their back. And a lot of times pelvic floor dysfunction can manifest with things like painful intercourse, pain going from like sitting to standing, especially if the iliopsoas muscles are involved, pain with defecation or having a bowel movement, or even painful urination as well. So, and that's a whole nother topic we can talk about in terms of pelvic floor dysfunction. But neuromuscularly speaking, if there's a muscle squeezing on a nerve, that's going to cause that nerve pain. So how do we treat neuromuscular vulvodynia? Well, if we've identified kind of the source, kind of where the issue is, and that lets us know what to do. If it's pelvic floor spasms, pelvic floor physical therapy is one of the first line treatments that I prescribe for patients. I'll oftentimes do a regimen of intravaginal Valium. Valium is a benzodiazepine type of muscle relaxer, anti-anxiety medication. If you take it orally, it a lot of times has a lot of kind of sedating effect. But if you take it vaginally or insert it vaginally, you don't have the same type of total systemic sedation. So I'll often have patients do 3 10 milligram Valiums throughout like a 24-hour period. So that's roughly 1 every 8 hours. I do that 3 days in a row. And if they get basically around a 50% reduction in their discomfort, then we can pretty safely say that the vulvodynia is secondary to musculoskeletal problems. Now, if the pelvic floor therapy is, working but not getting our final result, or if, a patient can't complete it for some reason, another really good option for pelvic floor spasm related vulvodynia would be something like an intravaginal Botox injection. So we do those, I do those, we isolate the muscle groups and we inject Botox, which is a muscular paralytic. It causes those muscles to relax. On average, patients can get around 3 months of relief with that therapy. And in that time, they're also doing the pelvic floor therapy to help retrain the muscles around that. So obviously, if it is something that's spinal related, then we definitely want to kind of talk to our, spine colleagues about that. Physical therapists, once again, are really beneficial for that. If it's related to a disc, you want to see like a neurosurgeon or a spine surgeon that does a lot of these type of procedures. If it's related more to the nerve root, actually where the nerves are coming out of the spinal column, a lot of times pain management specialists can actually target that area and inject that with a long-acting pain-relieving medication or steroid, and that can be really beneficial too. Now, a lot of times medications have been prescribed for vulvodynia that, have some effect. Sometimes they work really well, sometimes they don't. Common medications are things like amitriptyline, gabapentin, Lyrica, stuff along those lines. And those are fine. They're not treating the problem per se. They're just treating the symptom. And I don't like just treating symptoms if I can help it. Treating symptoms is fine while we're trying to figure out what the problem is, but I want to get to the root of the cause and treat that so you don't have to be on the medication forever. That's kind of my thing. So anyway, sometimes if we have patients that can't tolerate the Valium and they can't afford the Botox or things along those lines, I will use a more centrally acting muscle relaxer like tizanidine to help with those patients. I think it works better than something like cyclobenzaprine or Flexeril, but that's obviously another option for you to discuss. Now, some people, I have had patients come in and say they've had doctors do a compounded kind of pain cream to apply to the vulva, and that's fine as well. Once again, we're just treating the symptom. So we're not treating the actual cause of the problem when it comes to vulvodynia as itself. Now, vestibulodynia is a little bit different, and we can talk about that here in just a second. So anyway, that's about it for kind of neuromuscular things. Big things to think about is spine, pelvic floor, and kind of where that nerve is going. Obviously, any type of disease that affects nerve function, diabetes, multiple sclerosis, traumatic spinal cord injuries, things like that may manifest as vulvodynia. And in that case, it's a lot more difficult to treat it because you're trying to actually treat the nerve issue itself. And I think that's where we may see some use for things like protein-rich plasma and kind of nerve stimulating agents. That's theoretical right now. There's not a ton of data about that that I can directly point you towards, but know that hopefully that's kind of where we're going in the future for those related issues. Now, hormonal vulvodynia, is a little bit of a different story. Like I talked about, the vulva itself is very rich in estrogen receptors. The vestibule, I'm going to include vestibulodynia in this portion of this video as well, is rich in estrogen and androgen receptors. Now, as patients go through menopause, what we start to see, especially if they're not on any type of hormonal medication, is that vulvar tissue begins to retract a little bit. It can kind of pull inwards. The clitoris can kind of shrink. Basically, imagine the robustness of the vulva that's very full of estrogens. Kind of those estrogens are causing that plumpness to kind of go away. And what that is, that's related to a difference between what are called superficial cells and parabasilar cells within the actual tissue itself. Superficial cells are very rich in glycogen and water and help kind of provide plumpness. And as estrogen levels decline, those superficial cells kind of decline as well. So you're just left with the parabasilar cells, which are just kind of rigid and acting like a scaffolding to the tissue. Now, how this may manifest is kind of if you have irritation in that area, that could become more provoked with kind of a low estrogen state. Obviously, any type of small tears that you may get from things like sexual activity, trying to put in a tampon, trying to, have a gynecologic exam, things like that can cause those symptoms to be, more amplified as well. And so, topical kind of vaginal estrogen is the first line therapy for that hormonal vulvodynia. There are almost zero contraindications to vaginal estrogen. We give vaginal estrogen to patients with breast cancer. If you're worried about cancer stuff, that's a whole other topic. Like literally there are, I could maybe think of 2 contraindications to vaginal estrogen, and that would be if you're allergic to the compound the estrogen is in. You're not allergic to the estrogen, you're allergic to the compound it's in. Or if you have undiagnosed, vaginal bleeding, you don't just want to go throw hormones at it without figuring what it is. I guess there are a couple of other kind of very rare genetic disorders you wouldn't want to use that. But for the average person, there's not a contraindication to vaginal estrogen. What that will do is help plump that tissue back up. It will help with lubrication. It will help with the tissue elasticity and stretchability, because so much of vulvodynia, especially in postmenopausal patients, is, they're still trying to maintain a level of intimacy with their partner, and they get these little micro tears, and that's really uncomfortable. And those tears don't heal well. And when they urinate, urine gets on those tears and it stings like fire. And so that can be so life-changing for these patients. Now, vestibulodynia, remember that vestibule's different. Most common cause of a hormonal vestibulodynia is the use of oral contraceptive pills. And I want to kind of throw that out there, especially OCPs or birth control pills that have testosterone or androgen lowering progestin. So if you look at your birth control pill, you'll see 2 medications there, unless you're on a progesterone only one. But it will say the type of estrogen and the type of progestin. And the progestin is a synthetic progestogen, which is a family that progesterone is in. So that's whatever, chemistry there. But certain progestins lower testosterone, and they do that by raising a hormone that comes out of your liver called SHBG, or sex hormone binding globulin. And SHBG goes around and picks up free testosterone. It will pick up free estrogen. It will pick up some, thyroid hormone too. And when it's really lowered by those OCPs, when it's raised by those OCPs, it goes around and picks up more free testosterone than it needs to be. And that tissue that is in the vestibule that's very rich in androgen receptors is crying out saying, "Where'd my testosterone go? You took it all away." So OCPs that have a anti-androgenic progestin raise SHBG. I can't remember if I said lower it before, but they raise it. They make it too high. Shouldn't be high. Shouldn't be low either. That's a whole different story. But, if it's too high, that's the main cause of hormonal vestibulitis. And this is something that we can see, you take OCPs for 3 months at a time. You may have this problem for a long, long, long time until you go and you try and replenish the hormone, amounts in that tissue. So if you have a patient that has hormonal vestibulodynia and you look at it and you say, "Oh my gosh, this vestibule is red and irritated. Her Skene's glands," which are the 2 little glands up by kind of the urethra, are really red. You take a little Q-tip, you kind of poke on those very gently, and the patient jumps off the table. You say, "Aha, we've got a hormonal, vestibulodynia here." First line therapy, stop their OCPs if they're on them. Really stop any hormonal birth control if you can. And then do either a topical compounded estrogen and testosterone cream, or there's another medication called Intravaginal, which is an intravaginal DHEA that breaks down into an estrogen and an androgen. And it just is in that tissue, and it works beautifully for this. It's off-label. That medication is really only FDA approved for painful intercourse in postmenopausal women, but it's doing the same thing. It's breaking down that DHEA hormone into estrogens and androgens there to provide that, stuff to the tissue. Because, like I said, that vestibular tissue is so rich in testosterone receptors, you can't even believe it. Now, vestibulodynia by itself is a whole different thing, and there are other different causes of that as well, which we can talk about at a later date if a lot of people have interest. But hormonal causes of vulvodynia, like I said, the big thing is going to be replacing estrogen, and if they have a hormonal vestibulodynia as well, going in and replacing that testosterone too. So, and we'll see low estrogen states not only in menopause, but also in certain, patient... Well, my light just went off. Medications that lower testosterone and lower estrogen. We'll sometimes see these in patients who are going through chemotherapy, especially if they have a estrogen sensitive or receptor positive breast cancer. They may do that. Or we'll sometimes see this in women that do competitive weightlifting. Let me see if I can get a little bit better light. There we go. And they're on testosterone supplementation, and they're looking for something so their estrogen levels don't get too high. So anyway, that's kind of the main stuff for the vulvodynia talk. Obviously, if you have any questions, feel free to send me a message. I know these are brief, I could talk for hours on this. But like I said, send me questions if you have them. Thank you again for watching. If you like this video, like it. You can subscribe to the channel. I'm not monetizing this, but it's nice to know that people like, what I do. Share it with your friends, and we'll talk to you next week. So have a wonderful day. Stay warm if you're snowed in. Stay dry if you're wet. And I'm Dr. Corey Babb. Take charge of your own health.